Welcome to today's fourth session of this year's Thrive Series speaker series, which throughout the year with the ongoing growth of Thrive has now been renamed as Thrive Connect. This is refreshing growth for a program that was designed by and focused on those with an acquired neurological disorder, condition, or their carers, and is now giving us a direction that we can come together and will in time grow. Today we'll publish today on our YouTube channel because Amy's doing a fantastic job of videoing it, which is subtly, if you Google Thrive Aotearoa, it comes up. It's really easy to find. Thrive is anchored by the Pillars of Health, which is a framework and is designed by you for you. All Thrive activities are covering an element or multiple aspects that will ensure that individuals thrive to live their best life. Thrive is designed by individuals with the 5 pillars of health for Thrive being rest, move, chat, food, and mood, which is what today's all about. These are not in any order. These do not fit in a sequence other than we have identified these as essential for each of us to live our best life. The Thrive 5 pillars of health allow us to understand and in time relearn the essentials of life. Many of us who have a neurological condition or trauma have or are traveling on a journey of rediscovery, and the 5 pillars of mental health have allowed us to shape these into functional components to understand. Today's session is the 4th one for the year, and focus on the effects of something we all have and can be impacted very, very intensely after you've had some form of brain trauma. Your mood is often something. Oh, I talk too much about mood. Our mood is often something that is challenging to be aware of, and how it can affect you so much. But I can tell you from my lived experience that mood is easily measured, easily judged by others, and can determine how much satisfaction we get out of life every day in every situation, but an absolute challenge to understand at all unless you intentionally try to. For me, mood has been a transcending factor and is a beacon now when I catch a reaction or an overreaction that is not okay. And I'll often say that to my family. They'll catch me and they'll look at me and I'm like, well, that's my bad. So I'll often refer to my family and say to them, that's my bad, I'm sorry, I didn't get that. But I've noticed that as time has gone on, and I'm a huge believer in this, as time has gone on, I've got better at catching myself being bad, being that moody guy, being less moody, being a happy guy, and that's important. It's important to find that, which is cool. As many of you are aware, I'm an advocate, some of you will be aware, I'm an advocate for the concept of our brain's ability to amend its neural pathways, and believe that through knowing and in turn being aware of this, neuroplasticity is alive and well for us all, and in particular me. This is a forever battle, and the onus of this on me to continually work at it. The onus of it is on me to continually work at it. I'm fortunate to have a strong and positive relationship with the Laura Ferguson Brain Injury Trust, which I need to be honest was not called the Laura Ferguson Brain Injury Trust when I first started having my associations with it. It was just called Laura Ferguson. Sorry. I'm fortunate to have a strong and positive relationship with Laura Ferguson Brain Injury Trust. As a post-TBI patient, Dr. Leah Teschner will present to us today. I'm going to introduce you now. I thought Mary Poppins was in the room. Yeah. Was that a Mary Poppins moment? I can tell I'm a school teacher. My only wish for everyone is that everyone with a neurological trauma would have had the opportunity to experience the Laura Ferguson effect. I came to Laura Ferguson in late 2017, and from day one the connection and practice was a game changer for me. I wonder whether I would be standing here if it wasn't for the expertise of clinicians like Dr. Leah and her team. For me, truly a game changer. I owe so much to the Laura Ferguson Brain Injury Trust. Now a little bit about Leah. Is it Leah? Leah is Leah is the psychological clinical lead at Laura Ferguson Brain Injury Trust. Throughout her time at LFBIT, her clinical work has involved the assessing the rehabilitation needs of clients following injury, and collaboratively alongside the client and interdisciplinary team developing a client-focused treatment plan. That's a lot of work. The role of psychology in brain injury rehabilitation is focused on supporting clients to adjust their injury-related needs. Psychologists assist clients to develop strategies to manage changes in mood, sleep, difficulties, adjustment to their daily routines, and associated negative conditions which may develop. I think she might be the right person to help us at Thrive Connect today. And I just wonder whether your affection and your enthusiasm might be something that we can use in the future. I could go on, but I won't. So I'm going to pass you over to Lee to talk to us about mood. I would probably give you a rather interesting mood, but Lee's going to give you a lot better mood. Put your hands together to welcome Lee. You've got to turn you on. That's off. Oh, you're on. I can hear you.
Thank you, Craig. Lovely introduction.
Thank you.
You can take that with you, Chris.
Oh,
Start turning on.
Yeah.
I'll be in the back of the Lee. Speak loud.
Well, that was a lovely, heartfelt, warm introduction that kind of painted me in a very positive light. Hopefully I can live up to that today. Just a little bit of a clarification, I'm not actually a doctor. So anyone else? Yeah, no. I am, and proudly am, a clinical psychologist trained here in Canterbury, New Zealand. You can probably hear that I'm not originally from Christchurch. I'm actually from the northeast of England, and back then when I worked in the UK, I worked in forensic psychology, so I worked in high secure prisons for a number of years, largely involved in the rehabilitation of men that had committed quite serious offending. So I came to New Zealand with my family, I worked for a couple of years, and I went back to university and I actually retrained as a clinical psychologist. And since then, I have worked largely for Laura Ferguson Brain Injury Trust. I've also worked in specialist mental health, and I've worked with some child, youth and family as well. So I've had a little bit of a varied time, but I absolutely love working for the Laura Ferguson Brain Injury Trust. It is my longest employer, and the reason for that is that we are a trust and we are involved in rehabilitation, and for me what that means is helping people get back to a good quality of life. So a quality of life that they want to live, a quality of life that makes them enjoy what they do, And my role as a psychologist is so varied and so diverse that you don't really get bored, which is really nice. So our biggest stakeholder is ACC, so we get a lot of referrals from ACC, and we work mainly with traumatic brain injury and spinal injured clients, but we also work with people who are referred for psychological services, and that can range from anything from very like a mild trauma right through to a really severe trauma presentation. And we work with other neurological conditions, so yeah, we're quite varied. And we're a lovely big team, and we work as an interdisciplinary team at Laura Ferguson, so we work together and not up. So yeah, we all sit on the same sort of platform. No one's sort of seen more important than another, no discipline, and we lots of lovely experienced clinicians. So yeah, it's a really great place to work. So that's a little bit about me, basically. So what happens is I try to keep a very calm, what I call therapy voice as I talk, and then when I start reading, I sometimes go quite northern. So if you don't understand me, just put your hand up and be like, what did she say? And I'll do my best to try and keep the nice, calm therapy voice that I've developed over the years. Okay, so my presentation today, for some people, might be quite basic. For other people, it might be pitched at the right level, and for some, it might be pitched a little bit too high. There wasn't, and that isn't anything to do with Craig or the team here, but wasn't sure who was going to attend. So I've sort of pitched a presentation that hopefully is for everybody, but there is time at the end for questions, and there is time throughout. So if you have any questions, please just let me know, and I will do my best to answer them. But, you know, as I say to my kids, I'm not Yoda, I don't know everything, but I do my best. Okay. So mood changes are among the most common and impactful consequences of acquired brain injury and traumatic brain injury. And they can arise from direct neurological damage, psychological responses to trauma, and the challenges in adjusting to life after injury. Understanding these changes is essential for effective assessment, rehabilitation, and longer term support. So we do want to understand what was somebody's mood like prior to their injury or prior to the change in their life circumstances, and that gives us what we call a baseline. Now, I don't know about you, but if I thought to myself, what was I like 10 years ago? I probably look back with a little bit of rose-tinted glasses, and I probably look back and think about myself in a much more positive manner than what I might have actually been. So when we're looking back, we're asking the client, and clients' perspectives are the most important perspectives, okay? But we'll also, where possible, and with clients' consent, we'll also look back with what we call collateral people. So maybe their friends and their families or their work colleagues, and we'll get an understanding of where their baseline mood was. And for other people, they've had quite significant mood challenges throughout their lives, and they may well have already been involved with some of our specialist mental health services, or they were receiving psychological support prior. So we're looking at all of this to understand what was the baseline, and then from the baseline, we're going to look at how has the injury, whatever injury it is, impacted upon the person's mood. Because we all have mood, don't we? Like, we all experience fluctuations up and down in our mood day to day, sometimes hour to hour, sometimes minute to minute, really. Yeah, okay. The other thing that I wanted to sort of talk about before we go any further is I believe that mood is often seen in this negative light. It's often seen as like, what's your mood like? And it's not. Usually a question is asked in a, is it bad? Is it negative? Are you aggressive? Are you low in mood? Are you are you suicidal? You know, what's going on? Are you anxious? Whereas actually, we all experience mood. Like, every single human living being is experiencing mood. And trying to look at mood as something that is as normal as breathing, okay, without placing these connotations on it, is one of the things that I want to get across today. So yes, we do want to understand baseline mood and changes in mood, but we also want to accept that mood is something that we all have, and not necessarily always see it through that really negative light. So why do mood changes occur after a brain injury? Well, neurological disruption, for example, to the frontal, temporal and limbic regions, can alter emotional regulation, impulse control and stress responses. So the frontal lobe will control, is basically the main control centre. And when I'm describing it, I usually talk about your brain being like an aeroplane, and the frontal lobe is the pilot, and the pilot's driving this aeroplane for you. And sometimes after an injury, your pilot is a bit sleepy, or he's gone for a coffee, or he's relying on his mate to drive. You know, like, there's just a lot of changes that can happen. But the frontal lobe mainly deals with executive functioning, and executive functioning is just a really fancy way of saying planning, decision making, problem solving. Okay. The frontal lobe is also involved in emotional regulation, so it is involved in our calming, strong emotions, and controlling our impulses. And so it can be important in what we call inhibiting behavioural impulses. So you might want to do something, but you think, oh, it's probably not the best idea. But after an injury, or after an acquired brain injury, you may have less ability to inhibit your impulses. And so stopping yourself from acting on urges can become more difficult. So quite often people say to me, oh, when you get a brain injury, you become, well, not quite often, sorry, that was a bit of an exaggeration. People will say, well, when you get a brain injury, well, you're more likely to use drugs and alcohol, aren't you? Like, you become an alcoholic. And I say, well, that can be one of the things, but actually what's happened is you have difficulty with problem solving, with planning, and with impulse control. And so you are wanting to use things, and you're not necessarily thinking through the consequences more. So it's not quite as simple as everybody with a brain injury goes on to have all of these problems, but there's common problems that can occur. The other thing that the frontal lobe is helpful for is social behaviour. So it helps with our ability to be empathic towards other people. It helps with our judgments of other people and reading of social cues, and also helps with our motivation, so starting tasks, and not only starting the task but actually sustaining the task once it's been started, so following it through to completion. So what does that mean for mood? Well, damages here often lead to irritability and to pure frustration and emotion sort of intolerances, impulsivity, apathy and emotional dysregulation. So it can have quite a huge impact, and frontal lobe damage is often the one in my service that we see quite regularly. We see quite a lot of frontal lobe damage. But it does depend on what type of injury you have. So one of the things that I learned very, very quickly when I started to work in this service is that if I've seen one brain injury, I have seen one brain injury. And I think that's a really big thing to learn. You know, everybody is an individual, but you sort of think, oh, well, but if you damage this part of your brain, then surely it means that this has happened. Or if you damage that region, then it means that happens. That's not correct. And you can have damage in certain areas, like at the back, that affects frontal lobe and all these different things. So we do want to be really taking a very individualised approach to each injury, or any acquired injuries that happens. In terms of temporal lobe, well, the temporal lobe is involved in memory and meaning, really. So its main job is memory formation and storing your new memories and then retrieving your old memories. So it kind of helps with that ability. And it's also involved with language comprehension, so the ability to understand speech, which is the left temporal lobe, and emotion processing, and interpretation of people's tones of voices and people's faces. And also it is involved in threat detection, so it helps us to evaluate danger or emotional significance. So sometimes when you've had a change in your temporal lobe, you might overestimate danger or you may underestimate danger, and that's actually quite important, especially if you are parenting after brain injury or parenting after an acquired brain injury, or just out and about living your life and wanting to be safe. Okay? So why does that matter for mood? Well, injury can cause anxiety, fear responses, emotional lability, misinterpretation of social cues, and difficulties regulating emotional memories. And that causes problems not only for the individual, but for others around them as well. And the final part that's in my little point 1 is the limbic system. And the limbic system is often referred to as the emotional core. It's a network rather than a single region, and it includes the amygdala, the hippocampus, the cingulate cortex, and others. And its main job is around emotional generation: fear, anger, pleasure, sadness, stress responses, fight, flight activations. And also it has links to memory, so the emotion links are attach our feelings to a memory. So you might recall, I don't know, when I was 10 and I got this Polly Pocket toy, and I just remember it was the most exciting birthday ever, because I really wanted this Polly Pocket toy, and I got it. So that would be so exciting, as opposed to there would be other birthdays that I had and I don't really remember the things that I got. Does that make sense? Yeah. Okay. And also the limbic system is involved in our motivation and reward, so our drive and pleasure and reinforcements. So we generally as human beings do things that move us towards pleasurable outcomes, and generally stay away from things that cause us towards negative outcomes. But if you have impairments for either injury related or neurodevelopmental disorders, then that can be quite difficult for people. So why does that matter? Limbic disruption leads to heightened emotional reactivity, so we might see more anxiety, more panic, more mood swings, and we might see more difficulty calming down, so more difficulty with self-regulation. Okay. Point 2 is about neurochemical changes, so altered levels of serotonin and dopamine and I can't pronounce this word. Neurorepinephrine?
Should we try that for the audience so we can pronounce it?
I have practiced it, but I just got a block. Well, it's just a northern accent. That can contribute to depression, anxiety, irritability and emotional lability. So there is actually some neurochemical changes. I think back when I was more naive, as a psychologist, then I would have thought that right back before I trained as a clinical psychologist, I might have thought that everything was chemical related, and that's why you give everybody drugs, and that's how you cure depression, and that's how you manage anxiety. And then I learned different things as a clinical psychologist, and I thought, hang on a minute, that's not quite true. So, but there are neurochemical changes that can occur following either traumatic or acquired brain injuries or other neurological conditions, and actually they can respond incredibly well to medication. So as a psychologist, and as most psychologists would say, is medication has its place, and you really want to think about when is it useful, and when is it not so useful. So definitely not medication adverse, but it definitely isn't always the first port of call that a psychologist would use. Number 3 is the psychological impact. So this is where really I do most of my work in the role that I have now, which is around loss of independence, identity changes, and uncertainty about recovery, which can trigger mood disorder. Usually what happens for somebody who has a very severe injury is when they start to make some progress. They don't necessarily have insight, so their mood's okay. However, once they start to develop insight into how their life has changed, that's when we see either mood dropping and anxiety going up. So a lack of insight at the beginning can be a false sense that the person's okay, yeah, because they have got the insight to fully understand that maybe their physical changes are now lifelong. We do know that the brain is neuroplastic, and we do know that following a traumatic brain injury, the first 2 years is where the brain does its most neuroplasticity. It kind of repairs itself the best, and then it continues to repair, but at a slower pace. Okay, so the brain's always neuroplastic. Our brains are always regenerating themselves and learning new things, and that's why we can continue to learn right until the day that we die. But there is, after injuries, certainly for traumatic brain injury, there is sort of about a 2-year period. And so realistically, for some people right at the beginning of their treatment, psychology isn't important because they don't necessarily have mood disorders, or they don't necessarily have the insight that helps, that they need to then adjust. They're very positive focused. They think, oh, I'm going to go back to driving, I'm going to go back to doing this, I'm going to go back to doing that. When I've worked with people who have strokes, similar, that it's not always straight away that the person has the insight to recognise that their life has changed. And for some people, when the insight develops, that's when they get more changes in their mood. Okay? So just like I said earlier, mood is something that we all have. We sometimes think of it as a negative, think of it as something that's fluid and not necessarily a negative. But so if you're supporting people, you're just acknowledging what's the changes in their mood, and then we want to understand why, because hopefully then we can target that to help them have more stable mood. And another psychological impact after an injury is environmental and social factors. So for some people, their injury then means that they can't live in the house that they've lived in up to the point of injury, or it means that the house that they've lived in has to be adapted. Their car might have to be adapted. They may no longer be able to drive. They might have to have a driver. They might have to go into residential care. So there's so many changes that can occur for people after an injury. And social factors, quite often when I've worked with families, they tell me that at the beginning there were so many people who rallied around. The food was dropped off, the support text messages, the phone calls, just all of this beautiful support, and then over time it's tapered off, and not negatively. It's not because these people don't care anymore, it's not because they're become disinterested in what's happened, but life goes on, doesn't it? It goes on for all of us. But for the person with the injury and for their family, every day they're managing it. So quite often there's this inpouring at the beginning, which again is very protective for mood. If you're feeling very uncertain about your future, if you're feeling isolated because you're going to hospital every day to visit your loved one and someone drops you off a cottage pie, you know you have to cook, you're thinking, God, someone's holding me, someone's got me. Yeah? But if you're still 6 years later taking somebody to hospital appointments and then you've got to come home and make your own cottage pie, you might not feel as held and as protected. And then the last one is, again, another quite common injury-related change that affects mood that I see more often, is that people have reduced social contact. There's often changes in employment, and caregiver stress can amplify emotional difficulties. So I think sometimes we forget, and again, not to make judgments to anybody in the room, but we forget just how important caregivers are, and we forget just how much stress and difficulties that these caregivers are under to provide their loved one with the most beneficial support moving forward, and often not paid. So often classed as what's called as a natural support by, say, the ACC, in New Zealand. And so the natural support, they may not be paid, or they may be paid for X amount of hours, but they're still 24/7. Yeah, it's for those of you that have children in the room. We don't just parent in the hours that our kids are awake. We parent all night as well. You sleep with one ear open, one eye open. You know, people who don't necessarily live with their family members after an injury, they don't just switch off, even when the person doesn't live with them. So remembering that there's a lot of changes, not only for the person that's had the injury, but also for the people around them. And again, those changes can affect our mood. Sometimes more than others as well, I would say. Okay, so these are more of the common mood changes that I've seen after acquired brain injuries and traumatic brain injuries. So apathy, which is reduced motivation. So diminished initiation of tasks, appears similar to depression but without sadness, can significantly affect rehabilitation engagement. So often people that I have worked with that have apathy, they're quite flat in their demeanour, and they struggle with that task initiation, they struggle with the social cues, and that can be really difficult for somebody who doesn't know that they have an injury. And so they're thinking, well, why am I putting all this effort into talking to this person and they're not responding, they're not smiling, they're not nodding, they're not doing the things that I asked them to do. It's not because the person's like, oh, I don't want to. It's actually because they've got some apathy, and apathy is caused by the injury. So and then the other one that again is relatively common would be emotional lability. So people talk about rapid and unpredictable mood swings. They might be really crying or laughing, and it feels really uncontrollable, like they're not sure why. For any women in the room that's been through menopause or in perimenopause, you'll know hormone fluctuations have quite an effect on the females. So, you know, it's not always driven by your cognition, sometimes it's driven by what's going on biologically, and that's the same with brain injuries as well. And sometimes it can feel and appear to other people as very disproportionate to the situation. So people may I guess the classic example is laughing at, say, a funeral or a sadness when they're not being unkind, but they don't feel like they can control it. For some people that we work with, is post-traumatic stress symptoms. So if the injury was traumatic and if they recall the injury, so if they recall what was happening in the lead up to the injury, they may have intrusive memories about their injury. They may have hypervigilance to danger. They may avoid things that remind them of their injury, and they may have negative moods and arousal changes that occur. I suppose our more common that everybody knows is depression, and I hear a lot of the time, oh, he's just a little bit depressed. Who else has heard that phrase here? Yeah. And it's tricky, isn't it? Because I think as a psychologist, when I'm thinking about depression, I'm thinking about the DSM-5's categorisation of depression, and what's a clinical level of depression. Whereas when Joe Bloggs on the street is thinking about depression, they're probably thinking about mood, probably thinking about fluctuations in mood that goes up and goes down, okay? But in terms of depression defined by our diagnostic manual, we are talking about more persistent sadness or emptiness, loss of interest in previously enjoyed activities or not enjoying them as much, fatigue, sleep changes, appetite changes, feelings of hopelessness or worthlessness, and they often emerge weeks to months post-injury. So that's what I was saying about at the beginning, people look okay. People say, no need for psychology, it's all good, like you just, and I say, that's fine, great, we'll just sit in the background. And then something will happen, the person will gain insight, maybe they fail their driving test, maybe the support peters off, maybe they have had to have an adaptation to something in their home that they didn't think was going to be permanent, and actually the occupational therapist has assessed that this is going to be a permanent fixture now. And it's at that point that often they get their lowered mood, and sometimes that's to a clinically significant depression. The other one is anxiety. So excessive worries and fears or panic attacks, heightened startle responses. People become socially anxious due to either their thinking or their physical changes. So people who enjoyed socialising prior to their injury or their acquired injury may well find it more difficult now because their ability to process the information at the speed that they did prior to their injury is reduced. And with the best will in the world, it's really hard to remember that when you're socialising in a group setting. Even with like people that are really well versed, family members, that's the most common that we hear, is that people are trying their best to make the adaptation fit for the person, but the person is still struggling. And of course then that makes them much more anxious. And for some people, they don't want to go out in public because maybe they've got a hemiplegia, maybe they've got a weakness on one of their sides. For some of the clients that I've worked with, I worked with a man for quite a long time, and I smiled because he kind of called it his party trick. So while he was waiting for his titanium plate to be put into his skull, he obviously didn't have that sort of hardness that we all have in our skull. And through the day, his sort of head would deflate on one side, and he used to say his party trick was to hold his nose and blow, and it would pop up. He was a great client. He wouldn't mind me telling this story. He's a great client. But we worked together on wearing a hat, you know, so that people didn't stare in the supermarkets, people didn't ask. Of course, his work colleagues, his family, his friends, they all knew, so he didn't have to wear his hat then. But when he went out in public, he just wore a beanie, and actually it solved a lot of problems. The other one is around irritability and emotional dysregulation. So again, that quick shifting from calm to anger, that lower frustration tolerance, outbursts, impulsive reactions, difficulty calming down once people are upset, is all associated with that frontal lobe damage. So how does all of that affect our daily functioning, both for the injured person and for the people around them? Because I can't stress enough that an injury does not occur in isolation. I am the biggest, loudest advocate of this with everyone I work with. It really does affect relationships, and there's so many different things that can happen. There can be misunderstandings, there can be conflict, and there can be withdrawal. It's incredibly hard to keep providing care and love when people either are struggling to understand their injury themselves and adapt, or they're engaging in behaviours which you know are not good for the person, but they are still doing it anyway. And so that's really hard. And so marriages break down. People have difficulties with relationships with their children, with their friendships, with their work colleagues. So many different challenges that can happen. In terms of work and study, reduced productivity or difficulty coping with stress. One of the big things that I see in my role around traumatic brain injury is for people who work in the room, there might be things called glide time or time in lieu, you know, all of that kind of stuff, which if you are an uninjured person or your injury hasn't affected fatigue, then, which is really rare, you can still do, or you can do, but when you've got an injury, working an extra hour or two one day and then taking it back the next day doesn't work. Recovering from fatigue is so much different, and employers need to understand this. And so actually some of our role is about getting out and educating the employers and helping the employers to understand why you can't have glide time the way that why they did, or why the sweet spot for this client is 6 hours a day. 6 hour day, they're going to be really productive. You put them up to 7, they're not going to be productive, and you bring them down to 5, they lose their sense of fulfillment in the workplace because they know. And that finding that sweet spot is quite hard. In terms of rehabilitation, for some people, we might, if their mood is lower, then they may be less likely to engage with the wider teams. So if you think about, there's often quite a lot of physical rehabilitation, so physiotherapists will come in to work with people after an injury or after an acquired brain injury. And if your mood's low and you're not engaged and you don't want to do your exercises, or you don't want to use your fatigue management strategies because you just have got into a very dark place of thinking nothing's going to get better, then that's where mood can really have an impact, and psychology will come in and hopefully work with the individuals. It's not to say that it's only psychology that can work with somebody with a mood disorder, because actually what I say to my clients is, you see me 1 hour a week, come on, I'm good, but I'm not that good. You know, so it's the families and it's the other IDT, and a lot of the work is just giving people permission to understand that you don't have to have all of these fancy qualifications to know that your loved one has got a lower mood. You don't have to have all these fancy qualifications to spot that they're anxious. In fact, you can probably spot it way quicker than me as their psychologist because you know them. But what I can do, and how I describe myself as a psychologist, is I'm like a library. I've been to uni 3 times now, read all those books, checked them into my memory bank, and you come and see me and you check them out. And there's no late fees, and I'm probably going to help you understand them a little bit more and put it into language that you understand. So that can be really, really helpful for people. The other one is around understanding self-care, so reduced motivation for routines, appointments or exercise. So we all know what we should be doing, but when after an injury it can be very, very hard. There may be pain, there may be difficulties remembering to do things. There might be difficulties with actually physically getting somewhere, like getting to the gym or getting to the swimming pool. People might have more pain in the colder weather. They might have more aversion to like temperature changes, so they might have more aversion in the hotter weather. So really there's a lot of things that can impact upon mood and impact upon then their self-care. So what we do know is when mood drops, people often don't shower as much, don't brush their teeth as much, and then they're aware that they're not doing these things, so then they withdraw a bit more from people, and so it's a bit of a vicious cycle that can happen. And the big one is around community participation. So when mood is lowered, people often will have avoidance, isolation, or loss of confidence. So for example, if they go somewhere and their frustration tolerance is low, so I was thinking about someone that I worked with, and he went to pick up his prescription from the pharmacy and it wasn't ready, and he wasn't prepared for it not to be ready, so then he got quite annoyed in the pharmacy because he couldn't quite think through, oh, I'll just go out and sit in the car for 5 minutes and then it'll come back. Do you see what I mean? So these people may engage in behaviours that afterwards they feel really bad about, and then they don't want to go back. So it's such a vicious cycle that can happen. So what can you do? Because I mean, that's all this is what can happen, and hopefully I'm going to come with the ray of hope of this is what we can do. So being a psychologist, of course psychological therapy is number 1 on my list. At heart I am a cognitive behavioural therapist, which basically means that I like to look at people's thinking skills, their emotions and their behaviour, put it all together and help them improve. I have learned to be very good at adapting that for cognitive deficits, and there is actually lots and lots of research and evidence-based CBT for people who have traumatic brain injuries and other acquired brain injuries. The other therapy modality that has worked incredibly well, certainly within the traumatic brain injury world, I know it works incredibly well within the pain literature, and actually just generally as a psychological therapy, is acceptance and commitments therapy. And again, there's now more and more specific research and evidence-based adaptations being published in relation to traumatic brain injuries. And then the other one that we may work with is trauma-focused therapies, for example, eye movement, desensitization and reprocessing therapy, so EMDR for short, and we use that where appropriate. But again, we would work with the individual. So for some people who have an injury to their brain, the classic EMDR would be bilateral stimulation by following the finger. So you would follow your fingers. But some people can't track the eyes, so they may tap, or we might have therapy tappers. We'll do lots of adaptations so that people don't get prevented from accessing what is called the gold standard treatment to address what's causing their mood. Okay. The other big one is behavioural activation for apathy and depression. So when people are depressed, you know, when they're depressed, often they're not engaging in as much activity, and so we will work with people around behavioural activation. And what's really great sometimes is if someone's involved with a service, whether it is an IDT, so an interdisciplinary team, or even an MDT, then like a multidisciplinary team, then there is other disciplines that can work alongside psychology to really, really help. So you might have occupational therapists that are looking at fatigue management strategies, that are looking at going out into the community, finding activity for someone to do, supporting them to do that. You might have speech and language therapists that are working on social communication and communication skills, and you've got psychology that are targeting and using evidence-based therapy to target the mood, whether that's lower mood to bring it up to their baseline, or higher anxiety and bringing it down. Okay, so that's actually the best approach, I think. At Laura Ferguson Brain Injury Trust, we do lots of psychoeducation with our patients and with the patient's family. We run family groups, which is looking, not psychoeducation, more looking at how do we prevent carer burnout? How does the family members continue to adapt and to adjust to these lifelong challenges that now they're not directly facing. It wasn't their body, but it did happen in their family unit. And so we do a lot of work with families where appropriate, and we run family groups for people. We also look at pharmacological support like SSRIs and depression medication, mood stabilisers for irritability and emotional dysregulation, and sometimes you just really do need to utilise medication because it helps to stabilise so that then the psychological therapy can be much more effective. So if you're so low in your mood that you can't sort of retain and listen or even have a hope that things can change, then sometimes adding in that medication can bring the mood up enough that we can then work with the individual and they can sort of have some hope and think that things can change. Or if you're so anxious that you can't attend to what's happening in the session. So there's lots and lots of ways where medication really does have its place. And for some people who have a traumatic brain injury, they are prescribed stimulant medication, similar to what was prescribed for, say, an ADHD presentation, and that's because it's proven to be helpful, but that does need to be prescribed by a neuropsychiatrist. And then rehabilitation approaches, so structured routines and environmental support, goal setting and graded activity, fatigue management, social skills training, and cognitive rehabilitation to support emotional regulation and social and environmental support. So lots of different things that we can do. And the prognosis is that mood changes can improve significantly with treatment. Most people improve. They can fluctuate depending on fatigue, stress, and cognitive load, and they can persist long term if untreated. Early identification and intervention are strongly associated with the better functional outcomes and quality of life, but that doesn't necessarily mean that if you don't get treated for a number of years that you're not going to make gains. It just means that it might be slower than what it was if it was picked up in the first sort of 6 months or so. So I have got a little 3-minute exercise for people to do if everyone is willing to do it, and if you're not willing to do it, then that's fine, just don't do it. I'm not going to tell you off. Great, right? I'm not going to tell you off. Yeah, that's what I just said. Okay. So, for the first minute, I want you to become grounded. And what we mean by grounded is sitting comfortably and noticing your body's contact with the chair or the floor. So you're dropping your anchor into where you are right now. I want you to feel the weight of your body and the rhythm of your breath. Don't try to change your breath. Don't try to do anything with it. Just notice it for now. Notice whether sitting on this chair is comfortable or not comfortable. Notice whether your feet are planted firmly on the ground or whether your toes are there and your heels are up, or whatever's the most comfortable for you. You're just connecting with where you are right now. And in your head, just say to yourself, right now, I'm safe. And if your mind wanders, just gently bring it back to the physical sensation of breathing. Again, don't change your breathing, just notice it, just sit with it. Noticing where you are, noticing that you're safe, and noticing that your mind will do whatever your mind does, and that's completely okay. Now I want you to ask yourselves, what am I feeling right now? And whatever comes up, accept it and name it without any judgment. If it's sadness, some of the information I provided may well have created some sadness in you. For some it may be frustration, for others anxiety or fatigue. But whatever it is, just imagine it, name it without any judgment. Forget what you've heard about some emotions being good and some emotions being bad. And then place that emotion onto a bubble in front of you. And just observe it as if you were looking out the window and watching weather pass. Remembering whatever emotion you have is temporary. It will come. It will heighten. And then it has to reduce, even if you do nothing with it. Remembering that emotions are temporary, they're not permanent. And now coming back into our rebalance. So now I do want you to think of your breath. And I want you to just take a slow breath in through your nose. And then we're going to do it together if you choose to, because it is your choice. So we're going to breathe in through our nose. Hold it. And try and breathe out. And again, in through your nose, hold it, and then breathe out. Keep doing that, and I'm going to invite you, should you choose to join with me in a slightly different breathing. When you breathe in, I will count. You continue to breathe in as I count. I'll ask you to hold, and I'll count. Try to hold your breath. And then the really tricky one is trying to exhale the amount of times that I count. So if you choose to, you're going to breathe in, 2, 3, 4, hold, 2, out, 2, 3, 4, 5, 6, in, 2, 3, 4, hold, 2, out, 2, 3, 4, 5, 6. Just keep trying to do that with the breath in, and if you hold and you try to breathe out slightly longer than what it was when you breathed in. On your exhale, try to imagine releasing the tension or any heaviness that you have. Bring into mind something that gives you comfort. It might be a person or a place or a sound. Letting that image fill your awareness with just a few small breaths. And when you're ready, you can just bring your attention back to the room. And you can notice whether, and I don't need you to share, but you can notice whether that would work for you. What I can tell you as a psychologist is that your brain can take longer than your body to catch up. So we talk a lot about breathing as psychologists, and every client I have met has told me, I breathe, and I say, I know. Otherwise we wouldn't be having this conversation. However, how we breathe can be very important. And when we slow our breath, we make it slower and we make it deliberate, we breathe from sort of our diaphragm as opposed to our chest. We fill our lung capacity much more, and then when we breathe out, we are breathing out much more of the carbon monoxide that we take a kind of process in our body, and that creates a soothing effect. It can take sort of up to 3 minutes for our brains to catch up. So quite often people go, I tried that breathing exercise and it's bloody ridiculous. Like, I said, how many breaths do you have to do? 5. I say, well, that's the kind of problem. And luckily, hard to believe, but 20 years that I've been working in psychology, I know because I'm so youthful looking. We've got all these apps and different things now that can be so much helpful, because it's actually really hard to remember, what did she tell me to do? How many minutes? How am I meant to do this? But if you've got an app and you're using a Breathworks app, that can be really, really helpful to remember. So take a few deep breaths, which probably is what we all have heard many, many times, is not necessarily correct and won't necessarily work depending on how dysregulated your body is feeling at the time. Okay, so remember, up to 3 minutes before you can even use your frontal lobes to start challenging properly whatever's causing you distress.
So that's why you do yoga.
Yeah, yoga is a great, yeah. Yeah, I think so. Do you have yoga here?
No, they don't. It should do.
Yeah. But yoga is a wonderful technique, especially if it's adapted for people who, because they do adapted yoga and adapted Pilates now. It's a wonderful technique if it's adapted for your level of ability, largely because if you've ever done yoga, it's really difficult to sort of stay upright unless your mind is actually fixed on what you're doing. So you've got to really concentrate. You're nodding, so you've done it, I've done it too. If your mind wanders, you're likely to fall over in one of the poses. And also a lot of it is around the breath work, and so it's a great way of combining grounding yourself, which is the first thing I asked you to do, which is to plant your feet and notice your surroundings, clearing your mind and bringing your mind into I'm okay, I'm safe, and breath work. So it kind of brings it all together. So for some people, yoga is great. Some of the other strategies that we have are called cognitive strategies. So these are the ones where your thinking becomes more important, and so you can challenge whatever emotion you experience through cognitive strategies. It's not very easy to see, but the first strategy is name, notice, normalise strategy. So a fast cognitive technique for reducing emotional intensity. Name the emotion. This is frustration, or this is overwhelm. Notice where it's showing up in your body. So what's happening? Is my chest tight? Is my mind racing? Is my heart sort of going? And then normalise it. This reaction makes sense given what I'm dealing with. That's one of my big catchphrases in therapy. I say, would the average person, because I don't like normal, would the average person feel like this in this situation? And quite often clients will go, yeah. I go, okay, so we're in normal or average, whatever you want to say it. Remember that you're reacting the same as everybody else, because the minute you think that you're different, you're reacting different, the thoughts populate. So then you get more thoughts that go, oh my god, I'm different to everybody else, everyone's looking at me, oh my god, and they're noticing. And look, most people are incredibly self-focused and they don't necessarily notice what's going on around them. So those thoughts that we're having are not only unhelpful, but they're largely untrue. Okay, so that's your first strategy. The other one, and again, because I am by heart a CBT therapist, is simplified CBT reframing. So using a sentence and reframing it. So instead of I can't cope, which I'm sure most people in the room at some point in their life have had an experience where they've gone, I can't cope with this right now. And think, I can cope if I break it into one step at a time. I'm going to draw on Amy. So Amy is trained to be a clinical psychologist, and I can guarantee, because I've done the same training program, there's points where she goes, I can't cope with this. And then she goes, what do I have to do first? Let's break it down. And that's the reality, is that often we will have a thought, that is when we're already experiencing a mood or an anxiety, and we have a thought that says I can't do something, then it increases our mood or our anxiety. And if we reframe it and we go, I can cope, but I need to do it one step at a time. Or instead of everything is going wrong, sometimes things are hard, sometimes things are okay. Sometimes people say to me, I hate my life, and I say, okay, I can appreciate that you hate your life. Do you hate all of it? Is there everything in there? They say, no, I love my dog. And I say, okay, great. So you hate lots of things in your life and you love spending time with your dog. That's okay, just one simple challenge. Yeah, thank God for dogs, thank God for animals. Because they always show up for us and they never ever reject us usually. They just sort of sit there and like to be stroked. Apart from in COVID, where I think all the dogs hid. They were getting walked all the time. Like, not again. Okay. So keep your reframes short, keep them factual, and keep them present focused. And then that reduces the cognitive load while you're still shifting your perspective. So remember, it's really, really hard to really challenge what's going on in your mind if you're highly anxious or feeling very low in mood. So just a little reframe is good, okay? Then thought sorting, which is a structured way to reduce cognitive clutter, so lots of noise in our brain. Create 3 mental buckets. What's facts, what's feelings, and what's a prediction? And many distressing thoughts turn out to be predictions. And as I say to all of my clients, I am completely available to travel the world should you be able to predict the lottery numbers.
Yeah.
You don't need to share with me, but if you want to fly me out in your private jet, I'm good. I'm good with that. The Board of Ethics might have an issue. But often we believe our thoughts to be facts. I do sometimes. I get into this mindset of like, oh, I can't do that. You know, like when I turned up today and no one had told me we were being videoed, and I was like, oh my God, I can't do that. I can't be videoed. I'm not thin enough. I'm not eloquent enough. I haven't practiced enough. And then I was like, well, you don't actually know it until you try it, Leah. And then it went to, and if it's really terrible, you could just ask them not to put it up. Does that make sense? So it's just one at a time. And guess what? Even psychologists that have spent 7 years at university learning this stuff, reading the books, creating their own library, we still get anxious, we still get lower in mood, we still have lots of the challenges that the average person has. So yes, and then the last one is choose one grounding phrase. God, it's because I talked about being anxious and now it's like my body's failing me and going, show them that you're anxious. Go on, I dare you. So choose one grounding phrase and repeat it during mood spikes. So that's when you're feeling an elevation of either anxiety or your mood is low. So this moment will pass. I can handle it one step at a time. My brain is reacting. I'm still in control. Anchors help stabilise mood when cognitive fatigue makes regulation harder. So fatigue is so difficult. I think anybody that's had an injury, anyone that's involved with people that have an injury, you know fatigue just derails people. And it's actually one of the hardest things that I've experienced with clients getting on board with fatigue management skills. Everyone thinks they can do more. Everyone does a boom and a bust, and I go through booming and busting until eventually they go, oh yeah. And people struggle with cognitive fatigue as opposed to physical fatigue. So both are very hard, but often cognitive fatigue is just so difficult and can happen so much quicker than maybe physical fatigue for some people. Okay. So the last point I've got before I'm sort of on time-ish is my Super 6 for brain longevity. So move daily, okay, so to look after your brains. Whether you've had an injury, whether you haven't had an injury, whether you're caring for somebody, just move. Move, do aerobic training, do strength training. It's really, really powerful to sort of help against the detrimental effects of aging. What happens is that exercise rushes oxygenated blood to all of our lovely brain cells and then that fosters that growth of new blood vessels and helps us with neurotrophic factors. And so it's really, really helpful in the growth of new neurons and maintaining the health of existing ones. So do as much as you can within your limits. I think there used to be sort of a sense that if you didn't lift big heavy weights before, then you shouldn't lift big heavy weights now. But actually they're telling us that we get into that gym and lift big heavy weights, no matter what age we are, because that's super, super helpful. So yes, exercise. And then the other one is eat Mediterranean style. Now I've put a Mediterranean style diet, but really whatever Julia Routledge told you, just do what Julia said, because that woman is phenomenal, and the research she has done and her wealth of knowledge, just whoever went to listen to that talk, I would strongly advise it. The gut-brain connection, oh my word, like again, before I was a clinical psychologist, before I was privileged enough to have Julia as part of the university when I trained, the knowledge around that now that I have compared to what previously is huge, and just the amount of serotonin that's made in your gut is much bigger. We all think it's in the brain, but actually the gut-brain connection is huge. So please eat whole foods. I'm not saying that I do it all the time, but trying my best. Okay. Challenge your mind, especially for the 40 to 60 year olds in the room. So lots and lots of research to say.
Why 40 to 60?
Because we're forgotten. 40 to 60 is kind of usually felt when we're trying to look at a demographic. Often 40 to 6 year olds think they're okay. So they've come out of this younger, like usually when they've been at university or busy. And then there's a lot of research coming out now from Harvard University to say sort of really doing more learning, trying new things, learning languages, playing board games, jigsaws, all of them sorts of things that challenges you absolutely throughout your lifespan. But 40 to 6 year olds tend to just think they're okay. And it's not because they're suddenly that's the sweet spot for it. It's just we tend to think we're okay. So yeah, please, if you're all ages, but don't forget 40 to 60, because actually your life satisfaction you feel happier when you're about late 40s to 50s. We tend to have that nice sort of life satisfaction, and we might not do as many things. But yes, challenging your mind is incredibly important.
My parents are both 89 and next fortnight, and I reckon it's really, really cool. My mother goes to exercises and my father goes to yoga, and we're
Yeah.
trying to go to as many university lectures at Otago University, and they're really, really into it. So there's no way we will ending up with dementia.
Yes, yeah.
Stop this happening.
Yeah, yes, it is really cool, and it's really cool that there's so much more information out there about how our brains can age healthily compared to what was around 20 years ago. So stay socially connected. So again, as we age, it can be more difficult. Life gets busy, social connections fall off. It's not necessarily the volume of social connections you have, but the quality of social connections. So having one or two really good mates is what's important, and is really protective for your brain as we get older. And sleep, I know we all talk about sleep, but 7 to 9 hours is again very important for brain health. There are always going to be periods in your life where you don't have that sleep, but where you can, try and get back into it. And then managing other health conditions, so managing anything like diabetes, hearing, smoking, BP, like blood pressure, all of that again is very, very healthy for your brain, and even I think even probably more so after an injury, when your brain has already had some damages that sometimes don't fully repair. For some people, when I'm working with them, I say, hey, there's some things that you're probably never going to do again if they've got a severe injury. There's some things that you're going to do but with adaptation, so they might be able to drive but their car has to be modified. And then there's some things that you did that you can do just as well as you always did, like love your kids just as well as you always did, care for your, you know, care for people just as well as you always did, or other things like make a cup of tea. So yeah, so remembering that after any injury, sometimes for some people there's things that they won't get back to doing, some things that they will get back to doing with support, and some things that they can do just as well.
So alcohol would, that can affect your brain.
Absolutely.
Brain injury.
Yes.
Think about like Corsacox or something.
Yeah.
Does alcohol, does it affect the amygdala and then people get angry? Is that because
I think,
the amygdala is?
well, not necessarily in that way. I think what we talked, like what I was saying earlier, sometimes you have an injury that has affected your ability to inhibit a response, and alcohol lowers our inhibition levels. Yeah, it's incredibly dangerous after a traumatic brain injury because of seizure risks as well, because everybody who has, everybody's got seizure risk, everybody in this room, we've all got seizure risk. When we drink alcohol, our seizure risk sort of slightly lowers, but then as the alcohol is coming out of our body, it goes up. And so that's why alcoholics have to be sort of detoxed properly, depending on things. So yes, but it's not that it targets one region of the brain necessarily. It's more that it lowers our inhibition, so probably prefrontal cortex. Yeah, and then you engage in things that you probably wouldn't have done, like Dutch courage. I don't know if anybody, just have a quick Dutch courage used to be the thing. But it's certainly heavy regular alcohol use is detrimental for I would say everyone's brain. Yeah.
Is smoking, does that damage the brain?
Smoking can, yeah, it can sort of have difficulties with, I can't remember exactly what it does, but it's about your oxygen getting to your brain basically, and so if you starve your brain of oxygen then you get impairments, and for some people when the neurons are damaged, they're damaged like they can't be repaired, and for others sometimes there can be growth, so it depends on what's happening. Yeah. Good. Yeah.
You know, you know your gut intuition, what the right thing to do is, and people like, don't, yeah, and to, you know, you feel better if you exercise, you feel better if you eat healthily, you feel better if you sleep, you know.
Yeah, it is, and I think, you know, the term common sense implies that we have that knowledge in us, but actually quite often we have to learn it. So whether that's your family of origin, whether that's society teaching you, but yes, you develop common sense, but you were not necessarily born with it. And for some people, they are quite sheltered, like they don't necessarily have this knowledge. But yes, for a lot of us, there's so much more out there now about mental health, about, you know, exercise and how good it is for us, about how it unlocks that natural chemistry in our brains. So 30 minutes of exercise can be really helpful for helping to stabilise your mood. And it doesn't even have to be 30 minutes in one hit. It can be sort of like 3 10-minute slots. So walking from your car to work, which might be 10 minutes, walking back, that's 20 minutes done. And you maybe take the flight of stairs at work or walk around after lunch. Yeah. Yes.
Just checking, do we last all the way until 12 o'clock, or do we have a 5 minutes break in the middle?
Oh, I think I'm pretty much done if there's not any other questions. Yeah.
Yeah.
I had a question, Leah. I noticed a lot of people taking photos of the slides and
Yes.
wondered if you'd be happy to share them.
Absolutely, yeah. Yeah, absolutely. And remember that this is my perspective, and my perspective, I'm not Yoda. Remember that. So, absolutely, but I think there is the good baseline knowledge in there for people, but there's lots and lots of accessible information on the internet. You know, there's a much more funding now available. Yes, there are huge wait times, but there is the ability to see people through your GP for short intervention. We have health improvement practitioners now, so attached to some GPs again. So really taking action, even if you've suffered with mood for 20 years, it's taking action at some point can still be really helpful to get you to live a quality of life that you want to live and that you enjoy.
I mean, you need to just observe yourself, understand yourself, and observe, what works and what doesn't work, and why you feel it. If you can just, the mind be aware of.
You can have a mood diary.
Yes, yeah, and you are the expert of you, aren't you? Like, you know what your baselines are, and that's why we always say, even if, I don't know, like, say you're working with somebody and their parents say, oh no, they were like this, they were like that, whatever. Kind of that's their judgment of the behaviour, but the person often, unless there's a reason why you shouldn't take their self-report as the primary, often the person is, they know them, you know you. Yeah, okay. Any other questions? Okay. Thank you so much for listening. I'm not going to ask if it was helpful or not, because I actually don't want to know, in case anyone's like, no, it was terrible. But no one left, which is always my good one. So thank you very much for having me. Thank you. And I'll be around. I don't know what happens next, but I can be around and answer some questions. So really feel quite privileged to have been able to come and talk today. So thank you.
Can you de-mic?
Can I? Oh, yeah.
Yeah, turn off. So I turn this on below and away. Have you de-mic?
I think so, yeah. Yeah, I'm done.
Should we check?
Hello?
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 I'm back. You back?
I'm back.
You gone?
I'm quite loud anyway.
It must be that Geordie. Oh, did I say that?
I'll just educate you. I'm a smoggy. Geordie's in Newcastle. And we do take offence.
I still have thought that.
Yeah, you're on thin ice, Craig.
Oh, sorry. Leah, I just want to say, wow. You have blown my small mind away. A lot of my learning is on psychology, so I've learned that and also lived that. It's amazing to hear it from you. To get you from Laura Ferguson is amazing. I think to have you part of us. So you're now part of Thrive.
Oh, lovely. Thank you.
You can't leave.
No.
No. But I've got a wee card and a wee gift to say thank you. Here's my card. I wrote on
Thank you, Craig.
it. Here's my wee gift. I didn't do anything to it. And let's give her a big hand. Thank you so much.
Oh, thank you.
Just want to remind everyone, we do have our next Thrive Connect is on, look at Amy thinking.
September something.
Early September.
Early September.
A lot of you looked at slides, took photos of slides, really cool. I can see people being connected to it, which is very cool. We will make sure that the slides are accessible for you, whether we put them onto YouTube or something like that, whether we put them onto the YouTube channel. And we can do that, we got a connection.
I can email them out to you.
Yeah, or Amy can email them out to you. So it's all good. A full copy of this, of Lee's speech, will be very much on YouTube, so you can check that out on Thrive as well. That's if Amy recorded it. We're just gonna check, no pressure. She's just gonna press go. Great to see you all. Have a great day. And
Tea and coffee down the back.
Tea and
We've got
coffee
the
down
room
the
till
back.
12.
we've got the room till 12, so chill, relax, and mingle. Thank you.